Cool. So some patients here, let's play with diagnosis. Take a look at this photo. You're seeing a young patient with short teeth, more or less intact dentition except for some composite on the central incisor. And we're seeing a primary tooth that is decayed and non-restorable. Okay. Actually, I'm going to remove this tooth and replace it with an implant. Caution: when you're replacing a primary tooth, don't get fooled by the excess bone, because primary teeth have quite a bit of bone. And that's a mistake that is not correctable. What's the mistake here? If you're extracting the tooth and placing it where the bone is, well, the bone is in excess. The platform of bone is too coronal. You're going to end up giving the patient a primary tooth. It's going to look just the same if you don't reduce the bone. You actually have to do bone reduction. Okay, so it's another tip. And hopefully you remember that tip. If that's the only thing you remember from this whole presentation, I'd be happy, because it'll prevent you from going through a non-repairable complication of an implant that is too shallow. Okay, so for this patient, I actually recommended, obviously, the extraction. This is a patient type that has delayed eruption. Okay, and I recommended aesthetic crown lengthening and removal of the infected primary tooth. Here are the steps of the procedure: soft tissue reduction, full thickness flap. Here's the reduction of bone. Take a look at the bone, at how close it is to the CEJ. It's not supposed to be touching the CEJ. That's not how that's not what the anatomy book has taught us. Okay, that's an obvious case of delayed active eruption where we have to move the bone more apically. Can you use a laser for that? For the soft tissue, not for the bone. Even if it's a hard tissue laser, you won't get the finesse in bone, adjustment in bone plasty, osteoplasty, ostectomy, compared to what I'm going to instruct you in our courses. There are two burrs you're going to be using: the end cutting burr and the round diamond and the round carbide, to create a new shape of bone. Here is the round diamond. It's a medium size. It's like a number 6 or 8. And when I do my bone reduction, guys, check this out. It looks like a different patient. It's not the same patient that initially presented, right? We are doing bone reduction and we're doing bone plasty. We're changing the shape of bone. And I go into a lot of details inside the Masters of Soft Tissue and inside our aesthetic and functional crown lengthening courses. It's not something that I can review in a 40-minute presentation. Okay, but the details are very important. Don't just resect bone without knowing how much to resect, which tools to use, and how much. Okay, we don't want to remove too much. We just want to remove the ideal amount of bone, so when you suture, you can get a great result. Now, how about that implant replacing the primary tooth? Number one, I'm going to make sure to do some ridge reduction. Okay, so I reduce the ridge. Okay, it's almost always needed. Second, I'm going to make sure to bury the implant. So today's implants, for the past 10 years, with conical connections, can be buried. They can be subosseous without bone loss. Actually, they actually work better this way. And why is that important? If you have an implant that is deep enough, about 3 to 4 millimeters subgingival, you can, through a provisional manipulation, you can change the emergence profile, and you can then affect where the soft tissue is going to be. So number one, ridge reduction. Number two, bury it, because you don't want to keep it too shallow, because that's not going to look good. Okay, so that's actually one of our implant patients that has also delayed eruption. Okay,